thank you very much. First, again, I want to thank all of you for being here and for what you do for many patients, which I think as we continue to do patient advocacy, that is going to change the life of many more people moving forward. No? Next slide, please. So I'm going to try to talk to you today about, this disease and how it spreads to the lung. But first, I want to just to communicate to you why that happens. There is a normal physiology of the peritoneal cavity, and there is actually some fluid. As you know, in general, the peritoneal cavity, if you have not had any previous surgeries, is a free environment where there are multiple organs, but there is a physiology. There is a fluid that kind of moves pretty much from the left to the right and gets usually absorbed through the diaphragms. So that's one of the reasons why what we're going to talk about it occurs. No? But because of that, when you have a tumor that ruptures, like appendiceal tumor do, or any ovarian cancer or other cancers, or when there is a perforation or is a trauma in surgery, it can actually diffuse through all the abdominal cavity, as this is a free environment and it's connected through all the organs. Now, because of that, it can invade the diaphragm, and depending on the grade of invasion, it can go through, or it could be just superficial. And it happens in most patients with peritoneal dissemination from peritoneal cancers, including appendix. Also, surgical trauma. Many times, if you do the initial HIPEC and you strip the diaphragm, if you are not careful, you will inadvertently get into the diaphragm, into the chest, as the diaphragmatic muscle is actually very, very, very small. I mean, it's a very thin muscle, probably less than 5 millimeters in most areas. In some areas, are even just 2 or 3 millimeters. So it's a relatively easy way to get into the chest if you are not careful, and that is what you are trying to avoid if the disease is confined to the peritoneum. Or otherwise, there is a time where the tumor actually invades through, especially tumors, the low grades that have been there for a long time. Eventually, they work their way through the diaphragm just by increasing the pressure, and they do that. And so when we do actually a HIPEC in the peritoneum, of course, we look at all these areas, and that's why the reasons for laparoscopic HIPEC, unless you have minimal disease confined to an area, which is actually difficult to know unless you explore all the areas, you can miss disease behind. Or it can be missed in areas when people have so much extensive disease that, well, even though you thought you got everything, there are some microscopic cells in other areas. Next. So the tumor is spread in general by 3 or 4 potential mechanisms. One is direct spread, as we talk about it. You rupture and it goes direct into the peritoneum. The tumor can also expand or extend or metastasize to the lymphatic system. That's what the lymph nodes, the low-grade appendiceal tumors, they do not go to the lymph nodes, but the intermediate and the high grades can do that, and also can go hematogenous through the bloodstream to the liver, to the lung, and other organs. Although, interestingly, in patients with even high-grade appendiceal cancers, the metastasis beyond the abdomen is not as common as we see with other organs. And most of the problems related with survival are related to what happens within the peritoneal cavity. And the last mechanism is iatrogenic, either by doing surgery or doing a biopsy in the wrong direction. For example, if you have a tumor in the diaphragm, right underneath the liver, as you can see here, the diaphragm and the liver are very, very close together. And most of the liver actually and the diaphragm is part of your chest. So in order to get access to that, sometimes you will have to go to the chest to get to that. You want to avoid that because the possibility of a spread into the chest cavity is possible, as well as you do in surgery. In surgery, you want to be careful, as we said before, not to injure the diaphragm when possible. Sometimes it occurs, and then you very rapidly, you clean, make sure there is no contamination, and close it very rapidly. Next. So what are the indications for HITHOC? Now, as you all are aware, the hyperthermic chemotherapy aspects of the abdomen is well known. HIT has effect on killing cancer cells, but also enhances the effect of the chemotherapy. The pleural cavity is a more rigid cavity in which doesn't have that many recesses, or corners like you do in the abdomen. So usually HITHOC tends to be a faster procedure, although one of the limitations is that you don't have an expansion to do expansion cavity because of the bone to allow the area to expand. What it does with tumor increases is just pressures on the lung because it's the area within the chest cavity that will give up. So the lung, which is actually a balloon that expands, will be compressed slowly as the disease progresses. So what are the indications for this procedure? So there are two ways to do it. One is through the pleural cavity, directly, people who had developed disease on the chest, or in that case, the abdomen has already been treated, hopefully successful. Occasionally, there's still some residual tumor in the abdomen, but we'll talk later. We will try to focus on the chest first because that is what is going to create the problem by compression of the capacity of the lung. So we do HITHOC if there's a low-grade appendiceal tumors. On high grades, especially very high grades, with disease in other places, it's unlikely that will benefit unless it's only to try to keep symptoms from getting worse. We do it for both newly diagnosed or recurring tumors, okay? Or we do it when we are going through the abdomen and we have a tumor embedding to the diaphragm. We'll remove the diaphragm and then we look into the pleural cavity. So if that is the case, and we can clean the chest from the pleural cavity, we do that. We leave then the chest open and then do the perfusion into the chest simultaneously. We are doing the HIPEC. So really you'll be able to get dissection in both sides, infusion on both sides. Now, and that way it's only one operation. Next, how do we determine who are the patients who are really candidates for these operations? One is, of course, people have to be in the ability or able to sustain an operation. We make the decision based on CT scans, a PET scan, depending if it's a high grade. We want to make sure that the pulmonary function tests are there, although after HIPEC, after HITHOC, if you have a significant compression of the lung, your pulmonary function tests most likely are going to get better. And of course, we do the routine tumor markers, which not only allow us to know whether after the surgery, we remove all the possible tumors that the tumor markers came down and remain now. That is a good way to follow patients. Next. Then you plan the surgery. First is, what is the optimal approach? And this is true both for the abdomen and for the chest. In general, I use laparoscopy for HIPEC or chest only if it's something that is mainly for diagnostic. Unless you have very early disease where you really have a perforated appendix with no evidence of mucin anywhere else, which probably HIPEC is not indicated because now we are following many patients with perforation of the appendix that we have been followed for over 10 years, and very few will ever recover. Robotic surgery is more difficult to do when you have to do it for the abdomen, but you have to plan the biopsy correctly. If you want to know what's going on and you have a doubt, then the way you do the biopsy for the chest is very important. Also consider the potential risk for the surgeries. I mean, someone has high-grade tumors or has other confounding problems with cardiac history that are not able to tolerate major surgeries, then those patients have to be placed on the best potential improvement before you do a major operation. When you are dealing with large tumors that are associated with other organs without significant spread, you want to be able to remove that in block so there's no contamination in other areas. Frequently, this doesn't apply for patients that need HIPEC as they already spread throughout the abdomen or through the chest. It's more important when you have a perforated appendix that is attached, for example, to the bladder or to the colon. You don't separate the appendix to remove it. You actually want to remove that in block because that may be the only tumor the only surgery that people need. So the most important thing of any of the two surgeries, whether it's in the abdomen or in the chest, is to complete removal of all the tumor. And that actually relates into a better quality of life. Now, for low-grade tumors, you can leave a small amount of, disease sometimes that are not completely resectable. But for high-grade tumors, we have demonstrated that even leaving behind 2-millimeter tumors in high grade may affect survival significantly if you spend versus spending extra time to remove all visible tumor. So a patient actually did this for me, which was interesting. When I got to the operating room, he had written in his abdomen, you can see on the right side, the appendiceal surgery. They had done an open removal of the appendix. But he knew that now, as more patients know now, that if the surgeon doesn't spend the extra time to remove all the tumor, it's not going to happen. And interestingly, as you know, by the nature of this disease, they are all stage 4 cancers who really have expand all over the abdomen. And when that happens, you have to spend the time to remove it. And that's why we only do 1 HIPEC a day. I start in the morning, I finish when I finish, because I know that operation is going to be the most important aspect for that patient, and patient already knows that. When we do the HITHOC, there are 2 times to do it, simultaneously when it's unsuspected, and we find a surgery that there is an invasion on the diaphragm, and we reset the diaphragm, then we will look in the other side. Or independently, as we mentioned before, people who already had a successful abdominal surgery, or sometimes minimal residual disease in the abdomen, but the chest has become a problem now because had already spread there, and the issues with the chest are going to be more important initially as symptoms and survival than what is occurring in the abdomen. So that is why it's very important that we really look into this very careful and plan accordingly, because it's not the same for every patient. So here is, when we do the procedure combined, how do we do this? Is we do the normal abdominal surgery. And again, we resect the diaphragm. When the diaphragm is open, we inspect the cavity very careful, because sometimes you may have a tumor embedded into the diaphragm, but not through and through. If not through and through, then we will close the diaphragm. It's a combination of ways how we do it. We now prefer staples if possible, and with reinforcement with sutures. But if we suspect any evidence of involvement into the pleural cavity, which is a lining very similar, the one that we have in the abdomen is similar, it's a very thin mesothelium or pleura, that it's actually the same type of material, but it's very thin. When there is involvement of that, then we assume that it's going to be a potential problem. And we do this for even aggressive tumors when that occurs. And you can see now when the blue that just appeared on the right side, we are perfusing in one operation, both areas, both abdomen and chest. When it's only on the chest, then we do a thoracotomy, which is a removal of, cutting through the chest wall. And then we proceed to remove this pleura. The pleura is, again, a thin area that you can actually take completely, and sometimes also the pleura over the lung. Occasionally, we may have to do a small wedge resections of the lung to get all the tumor removed. And then at that time, once we completely remove everything, then we put the catheters, how we will do in the abdomen, and we perfuse the chest in a similar fashion. And at that time, we allow the lung to expand. When you do lung surgery and you want to really be able to remove everything, you have to do what we call a dual tube. We place a tube that has two tubes within itself, so you can block one lung from ventilation whilst the other one is working. So when we are working in the lung, in that side, that lung is collapsed to allow us to remove everything. But because the chest is a fixed cavity, really, it doesn't, it's not like the abdomen that you can check it and so on. We allow then during the perfusion, we again close the skin and the catheters are placed. We place the catheters in a way that allows a complete circulation to the whole chest cavity. But then we allow the lung to expand. So the lung itself is the one who really checks the chemotherapy and makes sure it gets everywhere else. So here, just to show you a patient that actually had a peritoneal surgery done. They went ahead and did a resection, but they entered the chest. They actually didn't recognize it until later, as there was extension into the chest, but they tried to put a suture there. And she came to us a few months later with this presentation. You can see, I cannot show, but you see the right side is nice and smooth in the periphery. On the left side, next, you will see these areas that I'm marking with red. This is tumor. The one on the center in the lower picture shows actually attachment to the pericardium. And when you strip the pericardium, which is what covers the heart, you have to be careful with the electrocautery not to cause any extra current, because the heart is an electrical organ. So if you put too much current, you can defibrillate it and patient can go into an arrest. So you have to be careful. But as you can see, it's really in the other area, you see how the lung is being compressed slowly. Instead of being smooth, the lungs start to give up because you are getting, pushing from the outside. It's similar to the abdomen. They start decreasing the volume available for the lung to expand normally. And as the disease progresses, it causes a restricted capacity. Fortunately, we have the other lung that can compensate significantly. A person can live without one lung if they are non-smokers and having good condition, but of course, not the ideal situation. This is actually the same patient now a year later. This patient was done a year ago, and now you can see that now it's nice and smooth. There's some scarring, but you can see even like that, there have been some compensation. You can see how bigger the right side is compared to the left. This is because we had to resect part of the lung, and then there is a compensatory mechanism from the opposite side. But so what do we want in general? And there is, when you hear numbers, you talk about people can talk about survival and percentage, but when you are dealing with a single patient, that patient has a different characteristics than a group of 100. And you have to kind of determine exactly for that patient what is needed. Can I help? Can I not help? And if I'm going to do it, what it means for that patient. Just to give you an example, some of you may know this man. I met him when he was 33 years old. Young man, he came to me on the November 2007 with rather extensive disease. I mean, if you look at that CAT scan, the liver and the upper one completely involved, the stomach, the pancreas, the spleen, and you look at in the lower one is the rectum, the sigmoid. I mean, it's just massive disease that was considered inoperable by X-ray standards. So I went ahead and operated. He actually recurred and became more aggressive from the low grade to higher grade. I got chemotherapy, it didn't work. I actually presented him in an international conference in Paris a few years later where all the experts were and no one wanted to operate on him even once. But just to summarize, he went to have 3 HIPECs every year for 3 years in a row. People thought I was crazy, but I'm happy to let you know that he's now alive. 14 years later, free of cancer, never received more adjuvant chemotherapy because it didn't work. And even though he had massive disease to be with, he had been able to have a normal quality of life. He had married, he got 2 kids, and runs his foundation and his company. So all that is why we do what we do, knowing that really change people's life. But as I mentioned, is you have to really make sure that the patient gets the best potential help, providing that even though there's a lot of data one way or the other, you cannot apply absolute things to any patient in particular. But patient needs to know that nothing is 100%, and while some people are successfully treated, others are not. Actually, this patient told me something that is interesting. He gave me this plaque. He said, Dr. Sardi, thank you very much. And to the whole Mercy team, and Sardi, it hurts. So it was kind of fun. Yes, this as the one of you who had this operation. It is a painful operation, but changed people's lives and cured many people as well. But this is not possible unless you have a team. I mean, this is, one of us who have been around for a long time, get the idea that, yes, the surgeon plays a very important role. The training of the surgeon, the willingness of the surgeon to spend the time needed to make it happen, because everybody has a lot of tumors, so it's very easy to say, oh, it was too much. And so people have to be trained on really dealing with all the organs within the abdomen and now the chest, but have to be able to provide the best care. So make sure that when you go to a center who say that those HIPECs, you are dealing with people who are very well trained and deal with liver, with pancreas, with spleen, with colon, pelvis, bladders, and so on. But you need a very good team. And one of the things that have been in many institutions, I've been at Mercy for the last 16 years, but I'm happy to know that Mercy is an amazing place because everybody loves what they do. But without the support of everyone, it is impossible to provide the care and results that we have. So what are the outcomes? Now, again, as I mentioned, these operations need to be performed in centers who have high volume, that have the experience, and surgeons have demonstrated to do it safely. Of course, everybody's going to have complications. Some people may die as possible complications. In general, you want to get people who publish a lot that they have showing the results. Also, not only for HIPEC, but also HITHOC, you need to be able to provide these operations in a safe manner because, this can have significant side effects if not done properly. Also, the length of the stay. For us in Mercy, I recommend people come from out of town to stay in town an extra week. The people who live more than 2 hours away, because the first 3 to 4 weeks is when people get dehydrated, they don't want to eat, food doesn't taste good. So it is very important that we are available 24/7 for patients, all the time, and that is how we do on Mercy. Now, we demonstrated, and we just presented the results of HITHOC at the SSO this year, last 2 weeks ago, and actually, clearly, if you do it properly and you remove the tumor the way it's supposed to be, removing invasion into the chest with appropriate patient selection are going to improve survival, and it really changed patients' quality of life. Next. And this is just to give you a summary of, we have been doing HIPEC for a variety of malignancies throughout the years. These are all the majority are stage 4 cancers. As you can see, and some of you may follow, chemotherapy results when stage 4 cancers are treated. If you see a 10% 5-year survival, a drug that costs $500,000 is approved within weeks. But here you can see that is very different. This is our results, but there are many institutions around the world that have similar results that show that people with a stage 4 cancer, not only we have many patients alive doing very well, but people are cured. In fact, if you look at the area that is encircled in red, you can see in years. I was a baby when I did the first patient, of course, but as you can see, 22 years and plus. This is actually a 1.5-year old slide, but you can see that people can live many years regardless of the type of tumor. Now, some cancers do better than others, but the most important thing that actually people forget is you have to get to the center who do the operation as soon as you can. And while it's not, no one has 100%, results, the earlier you get and you get the appropriate operation, the best opportunity that you will have. Why? Because once you do an operation and tumor grows into that scar, it becomes very difficult to be able to remove the tumor completely in the next time. This is very, very, very rewarding because it's very good to know that people with a stage 4 cancer can be cured. We have done over 1,000 surgeries now, and we have more than 680 patients alive. And this is for stage 4 cancer. So we are very proud of that. And thanks to the big input that actually Dr. Sugarbecker did many years ago, he went against the current and pushed against a lot of criticism. And he was the one who really popularized this. And, I did not train with him, but I was a friend of him, and I invited him to speak in the 1980s in New Orleans when I was there. And even though he was highly criticized, he said, wow, I was at that time a very aggressive surgeon, but without HIPEC, and I added the HIPEC, and that increased the results. And I think, like I told him many times, he deserves a Nobel Prize just because he changed the life of many people around the world just by pushing something that he believed on. And I think that's the important thing. Make sure you find a surgeon that is passionate about this, because if not, you're not going to get the best result. So what is the take-home message? Early referral is the key. The first procedure is the most important one. So if you get an appendectomy, make sure that before you get into the next operation, you research about it and see what needs to be done and why. Because the high-grade tumors, even when already spread, if you get them early enough and it's the first operation, we have demonstrated that people will do better. While the PCI, and all of you know what PCI is, the amount of tumor that there is important in survival. Just because you have a high PCI or high tumor burden, it does not mean you are going to do poorly. It had been a negative impact on patients because people had assumed that if you have a PCI of 20, you are dead. That is not true. If you get to the right center, even with high PCI, while you may do worse than other people, there are many people with very high PCIs that do very well. In our results, our average PCI is 27. So just to give you an idea that, even in the higher grade tumors, while that, of course, don't do as better as the low grade, you will still have some potential benefit and cure. Diaphragmatic invasion. Through diaphragmatic invasion, we have demonstrated now that the survival will be worse, but it doesn't mean you're going to die. But it has to be done. So if you are a surgeon that get to the diaphragm and now you are afraid to remove that diaphragm, then you are going to then lose the opportunity to give that patient the best survival that there is. Okay, so the other thing that is very important, we follow our patients every 6 months for 5 years, and then yearly until year 10. Why? As soon as we detect a recurrence, we go after it. And actually, our survivals have been very good because of that. We have people with 3 or 4 HIPECs. Now, in general, the second and third HIPEC are easier than the first HIPEC for the patient and for the surgeon. But in general, unless you have extensive small bowel resection and you are having a problem with quality of life due to the amount of resection that has been done, if you follow patients and as soon as you detect the recurrence, you should go after, unless it's a very old patient that has multiple issues that you don't want to do it. But even, and that's important. So people say, oh, wait and see what happens. When you wait and see what happens, usually what happens is that you will lose the chance to improve to provide the best results. At Mercy, we have now 3 surgeons who perform HIPECs. We just joined with the 4th one. He doesn't do HIPEC, but he does a lot of liver and pancreas and other diseases. But we have also a group that we are available all the time, and one of us is on call anytime during day and night to be able to cover if there's any problem. So there is, we have 2 manuscripts that have been recently published, and they're actually on the SSO. If you want to hear more about it, we'll be glad to submit it to you. You can also put in here different connections if you want to know more about us and get questions next. So these are just the 3 recent presentations that we did at SSO. But one is actually recurrent HIPECs that we used to follow up that show the benefit of being aggressive with recurring disease. Also, we have been very active. Last year, we have published over 44 manuscripts in multiple presentations. Last year alone on HIPEC, we had 17 publications. So we're a very active research program. Also, as Chris mentioned initially, I believe in global health. The world, what is happening here is happening all over the world. And actually, as you know, many of you are not in the United States. And I have been committed not only to my country, but now other countries have approached me to help with their developing plans for cancer. I have experience in developing cancer programs, but the idea is, how do we work together? And as you can see here, not only working together with the Susan J. Koch American Cancer Society, our foundation in the United States, and our foundation in Colombia, Mercy, and my patients through golf events and personal donations, but working together with universities and people in their country, we have been able to change the life of many people. And the question to all of you, how do you think you can help your community? As you can see from the point of view, and that's why I'm very happy to be here today, because PNP Pals, ACPNP, the Unintimidated Foundations, and many other foundations have been able to actually work together to help patients to get to the right place, but to do events that support education, patient care, and research. And I think this is what we need to do. Last year, this is actually, this picture was in 2019, because last year was all virtual. Hopefully this year, on September 21, it will be September 26, we have the Heated to Beat It event, and encourage you, many of you, to participate. It's going to be a combination of virtual and live, but most important, I want all of you to see how we can work together worldwide. Perhaps at some point, Chris, we should consider to do a world event simultaneously, in which not only major organizations would be interested in supporting, but we actually change the life of many people that are not getting to the right surgeon or right institution at the right time. And again, I want to thank you, all of you, for your participation, and I'm happy to answer some questions.
Dr. Sardi, that was honestly an incredible presentation. Thank you so much.
Thank you.
I learned something every time we do these presentations. I mean, really every week with patients. But I learned so many things today. I had no idea that the diaphragm was such a thin layer. I never realized that. And so I think it just, again, indicates the care and delicate nature of what you do in the surgical arena. It's just amazing. So really, really incredible. I want to let people know, if you have questions today, we have such a large audience, please email zoom@pnppals.net. If you've not already done that, we are collecting and aggregating the questions so that we can ask those of Dr. Sardi. And with that, Adele, I'll turn to you and ask you to start going through the questions. We've got a lot today.
We do. Okay, Dr. Sardi, this first series of questions is from a Lamin patient. And the question is for someone with Lamin PNP, are there usual or unusual spots that you see in the abdominal cavity for a patient with that pathology?
Are we asking about something who had it perforated or it had disease throughout the abdomen?
I think this is disease throughout the abdomen.
Okay, but let's actually go back and then, so the lamin, in the past it was supposed to be a benign condition. Now, with the new category, if you have just mucin throughout the abdomen, now you have a stage 4A cancer. Okay, so that had changed in the new classification of now. If you have a lamin, in the appendix without perforation, and you had an appendectomy with clear margins, that is all you need to do. If you have a lamin, which is a perforation, with perforation, but it has mucin localized only around the appendix, nowhere else, and no epithelium. When I say epithelium, the mucin is produced by a thin layer of epithelium, which actually, when you look at the microscope, it looks benign. And that is why in the past, people got confused and they, oh, this is benign, don't worry, go home. And 5 years later, we're seeing someone with advanced disease. If you have this epithelium, it means that you have that epithelium is spread throughout, and you have the potential to develop the big pseudomyxoma or the amount of extensive disease. The operation for low grade, which is the lamin, versus when you start seeing a lot of mucin, but now you see that epithelium is not that bland, less benign looking, it looks like cancer cells, which is now the higher grade. And then after that, you have the higher grade, which is the signaling cell. But just because you have one signaling cell, it doesn't mean that you are going to die either, no? But once it is spread, regardless of the type of tumor, it actually can go anywhere within the abdomen. Where do they usually go frequently? The pelvis. Why? Because of gravity. And the appendix is really frequently attached to something on the right lower side of the abdomen or in the pelvis, to the ovaries. That's why women, unfortunately, are frequently mistreated as ovarian cancers. They go in and they get big operation, and oops, it's the appendix, and now you had a big operation and making the next surgery more difficult. My recommendation, for example, when I talk to gynecologists, oncologists, if you go in and you see mucin, take a biopsy and get out of there. Okay, and then the patient will have one operation by HIPEC, which is the standard of care. But yes, to answer the question better is, regardless of what it is, it's going to be any place on the abdomen, and you have to look behind the stomach, underneath the liver. If you just look on the dome of the liver, you may miss a lot of disease behind. So you really have to look at every corner. And that's why, unless you have very limited disease that you probably will not need HIPEC, laparoscopic surgery is not going to be your best choice. Now, we have now over 50 patients that if you have a perforated appendix lamin, okay, without, just mucin outside without epithelium and not a high grade, we are following them without any surgery, by following them very closely in case they recur. Less than 5% will recur. So no need, we used to do HIPEC in all everybody because it was a perforation. That is not necessary unless it's already spread to other sites. Now, if you have a high grade or you have a positive margin, you're going to have to go back and clean that margin if it's a low grade. But if you have higher grade, you need to remove the right colon, because that once you have a high grade, it will go to the lymph nodes, or it can go to the lymph nodes. So you need to remove the right colon to remove the lymph nodes. But you don't need to do that in patients who have lamina. So sometimes people get, big right colon resection, but it was the low grade. They don't need a right colon resection. So the survival, when I look at survival, I'm not looking at whether people can make it to surgery. We do a lot, so people usually do very well, even though it's a big operation. We consider a success if we can have people alive 5 years later, free of cancer and in good quality of life. So what you remove has to be removed when it's needed, not to impact survival.
Thank you. And another question, so recognizing that imaging, mostly CT, has some limitations, is there, how much, once you're in and doing surgery, is there a typical amount of additional disease that you see that was not on the CT?
I can tell you that 100% of the time, there's more disease than what we're seeing on the CAT scan. Now, the other thing that is actually very important, now we are doing more laparoscopic surgery for high-grade tumors, and in order, because nothing worse for a surgeon than make a big cut and say, oops, I cannot help you, let's close you back, and now you have a big cut, and what do you do that? So what I'm using more laparoscopic surgery for diagnosis, see, especially looking at the small bowel, we pretty much can remove everything and actually still provide good quality of life, with the exception of the small bowel. You need at least 150 centimeters of a small bowel to have a good quality of life. So when I do laparoscopy, we can remove a lot on the pelvis, around the liver, underneath the liver, part of the stomach, the spleen. But the small bowel, if you have tumor involvement on the bowel itself, not the mesentery, which is what holds the bowel, you need certain amount to be able to. And actually, this week, I was happy to see that a patient that I thought on CAT scan I was not able to help. I was, when I look, there was really minimal disease inside. So I'm going to operate on her this week, in 2 weeks. So So laparoscopy. Now, the other thing important about laparoscopy is that tumor tends to recur in port sites, where they do the holes. So when I do a laparoscopy, I place my port sites in the midline, even though sometimes it's not the preferred, the more easy access. I put it there because I want to make sure that when I do the HIPEC, I'm going to be able to remove those port sites because tumor will grow there. And frequently we end up removing large parts of the right side of the abdomen because the port site was placed through it.
Dr. Sardi, I want to ask, so we've talked about small bowel involvement, and we had a presentation recently by Dr. Delia Cortez-Giral, and she talked about HIPEC, and she said they're having very good success with taking some patients. It seemed like it was just a little bit less than 1 in 5, but they were taking inoperable patients through HIPEC and reducing those small bowel implants. I don't know what your thoughts are on HIPEC, or if you've done any research on this new modality.
Yeah, I mean, we actually tried to bring it to the States. I don't know if someone is doing it in the States finally. We tried to do it, but it was not possible. It's pretty much for advanced cancers, try to create some palliation. In palliation meaning, if you have symptoms, and that's the thing, sometimes in cancer, and we will do that at HITHOC sometimes. If you have someone who has significant disease in the abdomen, but it's really not causing problem, but you are losing your capacity to breathe, then you can do, even though you want to go and remove all the tumor from the abdomen, you treat the chest and people will live longer and better quality of life. So that's palliation. So if you have a lot of ascites, then I have not seen yet a good published randomized study that showed that it makes a huge difference. No, and there is some cause and there is some potential risk, but yet there have been reported some benefits. The problem with HIPEC and HITHOC is that, at the HIPEC is that, you want to treat people with small amount of disease because the chemotherapy itself penetrates very little. The HIPEC, what it does with the pressure, you're supposed to have a little more penetration, no? But really the penetration and why we talk about CC1 of less than 2 millimeters is because chemotherapy will not penetrate big tumors. So the limitation with HIPEC is, if you have big tumors, it may reduce more than the HIPEC will do because we don't do HIPEC with a lot of disease. Now, having said that, I have now learned throughout the years that if we have a patient with a lot of tumor that we can remove a lot on the upper abdomen, and clean the small bowel, but it's still disease that cannot be removed, we'll still do the HIPEC because it reduces the complications of the bowel recurrence. People with these diseases usually die because of pressure by intestinal obstruction. And if you look, for example, at ovarian cancer, which most of the people used to die from intestinal obstruction, now we have changed the natural history. We cure many people, but the people who are not cured, they're not dying because of recurrence on the abdomen. Now they have recurrence on lymph nodes 7-8 years later that we didn't know it was possible because people were dying sooner. So so you are delaying even or changing the way people are going to get to die and living longer and good quality of life. So that is a combination by HIPEC. It's something that may have some benefit. I don't know right now who will play a major role, but I think we still to learn more about it.
Very good, very good. I want to build on some of the things Dr. Sardi has said, and I want to remind all of us. I know some of these statistics can be scary, as many of us are new on this journey. But I just want to reassure you, as a 16-year survivor, again, Charmaine, over 22 years, that truly, I never thought I'd be here at this moment. We do not know what's going to happen. And so I just want you to not be discouraged and remember that there is hope abundant on this journey, truly. We are absolutely at a time in our world where new technology and new advancements are happening every year in chemotherapy, in surgical techniques, and new tools in the surgical theater. So I just want you to have hope as you're embarking on this journey. I did also want to remind folks that we do, every month, we have a physician presentation. In fact, on May 1st, we'll have Dr. Melanie Angchen from UPMC, who will be speaking with us. But the other 3 weeks of the month, we do a patient support call at this same time every week. And we've been doing this for a while, and we find as difficult as the physical journey is that we all go through, the emotional journey can be equal to, if not greater than. So we will be here every week on Saturday to support you, to answer any questions that we can. It's a great time for us to discuss, for us to have fellowship as patients, which is so unique, so fulfilling, and so rewarding, just to be able to be with others who know exactly what we're going through. I'd encourage you to come back, and we hope to see you again. Dr. Sardi does have to go after an hour today, so we're going to have just
I can stay another 15 minutes or so. It will be okay. Yeah.
Well, we will take, if you're offering, we'll take it, Dr. Sardi. Thank you. Thank you. Adele, you want to move to the next question?
Okay, sure. Can you talk about detection of disease that might occur after 11 years or so?
Yes, it's usually rare. Usually it's disease that probably hasn't been recognized on previous CAT scans. It can happen, but it's rare. Most of the recurrence will occur in the first 3 years, especially for the high grades. By 5 years, you will see something. And between 5 and 10, we see about 2 or 3%. Beyond, it can occur, but probably if you go back and start looking at CAT scans, probably that was missed and it was been there for a while. Because the low-grade tumors are very slow-growing tumors, and it can take a long time to do that. But as soon as they are detected, especially on young people, my recommendation is to be aggressive, because if you are 85 or so now, I actually operated on Tuesday a lady who had been alive for 21 years. She had went to a UIN. They did the lamine or pseudomyxoma, told her not to worry about it. And then she presented Dr. Sugar-Baker that removed a lot of tumor in 2015. He couldn't do a HIPEC because it was extensive. She came to me with disease growing everywhere and coming out. She having a quality of life, and I just went in and took out the fistula, clean as much as possible, and she's very happy, ready to go home now. But so you can do things without having necessarily be HIPEC all the time, even people with a lot of disease. We are waiting for something that had been on hold for about a year, which is the administration of the pineapple extract. Which is the idea is that mucin is jelly. So for a group of people, sometimes you can have these sacs that are just pushing and pushing, but not able to get there anymore. So the idea is that you put this in a little through a catheter. It will melt the mucin, so you can suck it out like water. And so that has been in some preliminary studies to be very good. We are waiting to start that trial. It's supposed to hopefully start within the next 5 months, but we still, there are some limitations yet that are not clear completely. But so people are looking into ways to even help people that are not candidates for HIPEC.
Yeah. Well, we had several questions on the bromelain study, so you answered all of those with your answer right now. Thank you. What about for someone that after their CRS HIPEC they have remaining disease? How does remaining disease affect long-term quality of life after the first CRS HIPEC? Okay, so the first thing to do is to see where was the remaining disease and why was left behind. I usually look very careful at the operative note, because there are resections and there are resections. Sometimes I have a patient that said, "Oh, I didn't feel comfortable, to go to the liver, or and that area was left alone." So so the other thing that we don't know and we have seen is people that even we left tumor, that because it was too many on the bowel, but there were several areas that we already resected a lot of bowel, but we don't know the effect of the chemotherapy itself. These people we have been able to follow for years and they never recur, even though we left tumor behind. So obviously the chemotherapy has been done. How do I approach that? I will look at the operative note. I will look at what happened to the patient, how they're doing, what was removed, and then we assess the situation. And depending on how they're doing and how everything comes, some of them will take it back to surgery and try to resect them if it's possible. We tend to be very aggressive, but we have to be careful that, surgery is like chemotherapy or radiation. You need to do it when it has a good chance to helping people,
not just because I can do it. You know what I mean? You know, if I can help people and the chances are good, then it makes sense. Because otherwise you can hurt people that shouldn't be operated on. You know?
Now I'm going to take a moment and do a brief Dr. Sardi commercial. In my personal journey, I was diagnosed in 2004. I was lucky my father found PMP Pals on the web and Gabriella Graham. And she said, Chris, you're going to go. I went to 2 local hospitals, world-renowned in the Bay Area. I'm not going to name their names, but they just weren't believers in HIPEC at that time. And I was given a grim diagnosis. Gabriella gave me hope and helped get me to care. That's exactly what PMP Pals does today. Our only mission is just to give you options, help you become educated so that you can advocate for yourself, which is really essential on this journey. But I went to MD Anderson in Texas. I went to NIH in Bethesda in Washington, DC. I went to Paul Sugarbaker in Washington, DC. And then I eventually stopped and saw Dr. Sardi. And I immediately saw his heart and absolutely loved the balance that I heard from him. I hear that again today. We can be aggressive, but no more aggressive than we need to be. And we're certainly not going to just operate for the sake of operating. So a really good balance. And I've had the pleasure to meet not just Dr. Sardi and his wife personally, but I've met his family members, truly an incredible family, and always a very good choice if you're looking for options. And we always suggest get lots of opinions, get lots of options. I'm not just saying I learned something new today. Every time I speak with one of the specialists, I learn something new. So we encourage that. I'm sure Dr. Sardi would encourage that too, but he's definitely someone you should consider having on your team.
Well, thank you, Chris. Actually, it has been an honor to take care of you. And I told Chris many times to call me Armando, but he called me Dr. Sardi, you know. But anyway, no, it's an honor for us. I mean, for the ones of us who do these operations, I mean, what reason why we keep doing it is because the impact that has on people. Yes, and I do encourage when people come to me and they have a second opinion, and you know, I have a funny accent, and we are in a relatively small institution that do amazing care. But I tell people you need to go to the institution in which you trust your surgeon. Just a big name on institution does not mean better results. Yeah, there are many big institutions who have great results. So make sure that you meet with the people. But then once you make the decision, just focus on your well-being. You know, don't go in the internet and try to figure 100 times, understand what is going on. You have time. If the surgeon tells you, I have to operate on you tomorrow, don't believe it. First, unless you are obstructed or bleeding or something, you don't need an operation tomorrow. Okay, this disease by most times have been there for years really. So 1 more month is not going to change your survival. Second, make sure that you understand exactly what's going on with you and understand what it means. In order to attract, some people can say, oh, I'm going to cure you. Yeah, I mean, we all try to cure you, but it's not 100%. Now, are you going to be in the 1% that, or on the 99%? It depends on when you are in the good side. I always aim to be on the good side, but only time will tell. But one thing that I tell everybody, you need to enjoy life, because that's what it's all about. I had the unfortunate event that I lost a child at age 2. He drowned in a pool that I built for him. I was 25 years old. And I learned that we don't own anything, but we have to enjoy life. And I already have my heart cert, my heart stents, and all the things, but life goes on. We're all going to die from something. And it doesn't matter. It doesn't mean that when we're going to die is from what. So in the meantime, we have to do the best we can to have as wonderful life as we can. Even with the pandemic, they told me, and administration at some point, oh, you have to stop HIPEC because it's not emergency. So I said, what? I refuse that. Why? Because HIPEC is an emergency surgery. In other words, the number of people who doesn't have HIPEC are going to die for sure. And I'm going to stop doing that just in case someone gets COVID and die, which actually in our hospital wasn't as serious as in other hospitals. And also, if you look at the mortality last year, more people die from heart disease, more people die from cancer, and the third one was COVID. So even with this huge death last year, heart disease and cancer surpassed the death from COVID. And most importantly, is that many people who had heart disease and cancer were not taken care of because of the COVID. So, it's a balance. We have to live. But I tell people, find your best doctor that can take care of you. Make sure that you trust that service and go for it. But enjoy life. It's a hard road. This is a big bump in your life. I always said that the life is like a stock market. Go up and down. But if you do it well, it keeps going up. And you strive to do that. And I think that. And I think that's important. But, Chris, thank you very much. And again, it has been an honor to be your doctor.
Oh, thank you. Thank you so much. Now, this has just been an amazing presentation. Our founder, she lived 16 years, always with disease, 85 pounds toward the end, diminutive, but a spirit of a tiger. So every patient deserves a chance. And one of the things that we say in our patient support calls is, as rough as this journey is, it does give us the chance to explore these topics that you've talked about, right? And realize there's life abundant, even in the midst of tragedy like this. And so, but it takes conscious effort and focus. And we have to make smart actions every day to look for the positive, to encourage ourselves. And when there's bad days, we support one another. That's what we do at PNP Pals. But to your point, just try and make it a little better every day. Progress, not perfection, for sure. For sure. Well, Adele, do we have any more questions?
We have just a couple. I think they're quick. So just two more. So you'd mentioned that oftentimes women it's diagnosed as ovarian cancer. So if someone had a prior surgery, how long would they need to wait to have their CRS HIPEC?
So the way I do it is as follows. If you have a low-grade tumor and you just remove the ovary, then you really don't have to wait more than a few weeks, the 3 to 4 weeks maximum, to allow people to recover. If you have a total abdominal hysterectomy, a pingo-forectomy, the whole thing was removed, then in that case, I want to wait about 2 months if you have a low grade. If you have the higher grade that is going to need chemotherapy, even though we know chemotherapy today, the benefit, in appendix cancer is still very controversial, then we'll give 3 courses of chemotherapy. And then after 3 courses of chemotherapy, we wait 4 weeks and take it to surgery. But for the low grade, usually, why is that? After any major surgery, and I'm not talking about an appendectomy, but after a major surgery, you have a significant amount of inflammation. Let's say if you have all this mucin, and then they cut the vessels that go to the uterus, the vagina, and so on, there's going to be some inflammation there. When I do the operation back in the pelvis, I take all those areas out again. Sometimes just a little bit of the vagina to make sure there is no mucin trapped into those sutures. But if you have a lot of inflammation because of recent trauma, surgery, then you can end up taking more out that it doesn't need to come out. So again, because it's a low grade and you can wait 2 months without a problem. Usually after 6 to 8 weeks of a major surgery, the inflammatory process has resolved. And again, if you have a high-grade tumor, then we will do just treatment with FOLFOX, no Avastin, because Avastin will delay things. Wait 4 weeks and the patient goes to surgery with the idea, of course, in between we get the tumor markers to see where you are and what is happening and have an idea.
Thank you. What can you tell a patient that has mucinous adenocarcinoma with lymph node involvement in terms of future treatment and prognosis?
Yes, I'm assuming that the lymph node involvement is along the right side of the colon. Yes, one is where the whole tumor was removed, very important factor. Okay, if you remove all the tumor, the average survival in our hands at 5 years is 65%. Okay, now, again, it has to be a complete removal of all the tumor. If you have residual disease, then that survival goes down significantly. Now, sometimes if they did not have the they had a right colectomy, but didn't remove everything. Again, we'll give 3 courses of chemotherapy and go back and do everything. But again, don't focus so much on numbers, because numbers is like pretty much throwing a coin. No one can tell you not only how long you're going to live, and when a surgeon tells you or a physician tells you, oh, you have 2 months to live, no one can tell you that. I've been surprised. I have people who should have been dead 5 years ago. They're still going. So no one can tell you that. Second, the operation, that is done determines what you did. But again, you never know. So don't focus on 50%. I know, it's not 100%, which pretty much nothing is 100%. But I have a chance, and even if the chance is 20%, I want to take the chance, because otherwise, if you only get chemotherapy and nothing else, your chance is 0%. You know what I mean? If you look at the result from chemotherapy and when drugs are approved, if you improve your survival by 2 months, that is considered statistically significant, even though you are not going to be cured. HIPEC results are overwhelming beyond that. And even chemotherapy on appendix tumors are still very controversial about the potential benefit long-term. So we use it as a combination, but not as instead of surgery. The other thing that I have been a little, and I think this is very important, what you guys are doing, is that misconception by physicians about the outcomes of this operation. We actually put a brochure that we sent to 8,000 physicians, which we'll be glad to share with you. Send it to you so you can. It's a PDF that shows the results of 25 years. So while it's not 100%, it shows that is pretty significant, and most people do pretty well. It's a big operation. It takes 2 months to back to normal. In our hospital, they stay out an average of 10 days. But it's a big operation. Food doesn't taste good. It hurts for a while. And I have people who take longer to recover. But I have people who were mad with me for several months, and 8 years later, they are loving me. But this is the chance that most people have when possible. Now, not everybody's a candidate for it. No?
Well, at PNP Pals, we're firm believers that patients deserve choices, and you're offering many choices today. And that's what we do at PNP Pals as well. We just do our best to make sure patients know they have options. And Dr. Sardi, you're an incredible one. Thank you so much for this amazing education today. I really, really appreciate it personally, and I know everyone else does too. Thank you for being here.
Thank you very much for everything, and thank you for the invitation. No?
Absolutely. And again, I will remind folks, we are here every week, 11 a.m. Eastern on Saturdays. We'll go for 2.5, 3 hours next Saturday, just going through patient questions and supporting them. We're happy to do that for you too. You see a number of programs that we do every day of the week, offering care, support, love, and we'd encourage you to take advantage of them. And please do remember that PNP Pals is completely donation run. We don't make money at this. This costs each of us time and money. And so we would ask if you would be willing to generously donate. Consider going to pnppals.net to do that. There's our website. We're on Facebook and on Instagram as well. And so we hope to see everyone next week. We thank you again, Dr. Sardi, for being here. And everyone, make it a great week, and we'll see you soon.
Thank you, everybody. Goodbye.
Thanks so much, everyone. Bye.